microphone. Hi, I'm Carol Runyon, Director of the Program for Injury Prevention Education and Research here in the School of Public Health. And I'm pleased that we are able to sponsor a seminar series more or less monthly. And this is our September session. We don't have October lined up yet, but stay tuned. Please fill out the sign-in sheet that's going around. And if you're not already on our mailing list, we'll make sure you hear about future seminars. And also we'll have an evaluation at the end that we would appreciate you filling out. I'm curious, before I introduce today's speaker, how many of you are students in public health? Students in medicine, nursing, pharmacy, dentistry, other disciplines? Faculty, public health or medicine, and community members? There's a contingent here maybe from Kaiser? There you go. Okay, good. Great. Well, I'm glad to have a mixed group with some familiar faces and some new faces as well. So I'm really pleased that we were able to recruit Jennifer Boggs to come over and talk about some of the work going on at Kaiser. There's a lot related to suicide prevention. Jennifer has her MSW from Denver University, and it's currently is a project manager at Kaiser, where she's been for the last 7 years in the Institute for Health Research. She's also a PhD student here in the Health Services Research Program in the School of Public Health. So wears a few different hats, and I'm just looking forward to hearing more about the work that she's been involved in and having a good discussion.
Hi, can you guys hear me? Thank you. I'm very happy to be here today talking to you about some of the suicide prevention work that I've been engaged in for the last 7 years since working at Kaiser. So I have to, of course, acknowledge that this work does not happen by one person. There's a very large team that has grown since I've been there. Our team is led by Arnie, who's over here. And we also recently recruited Sam Hubley from the family medicine here at the university as an affiliate investigator. And then we have a lot of other folks that help us with our work every day, and several of them are sitting right there. So it's really great. I'm really happy that some of the folks from Kaiser came today, because if I don't know something, I am sure they do. Okay, so I'm going to start by just giving you a little bit of background on suicide. If anyone who knows is familiar with suicide research, probably this will just kind of be a review for you. But so we'll start with that, and then I'm going to jump into looking at what Kaiser does to address patients that could be at risk of suicide. I'm going to talk a lot about our data systems, a little bit about the methods we use. And then I'm going to do a little review of the Mental Health Research Network, which is a large network of different health systems similar to Kaiser around the country that we are a member of. And then I'm going to try to tell sort of as I was telling Carol, like a main plot line, starting with how we try to address the question of how we whether or not we should be screening patients in the primary care and general medical settings. So starting with observational studies and kind of leading up to a large clinical intervention trial that we're doing right now. And that trial is called the Suicide Prevention Outreach Trial. It is the largest trial that NIMH has ever funded on the topic of suicide. And then at the end, we'll kind of open up to some discussion, and we can talk about some of the gaps in knowledge that we've identified throughout some of our observational works, and where we see we can kind of talk about what next steps might be. Okay, so 2 main objectives for you guys today, especially for the students in the room. I hope you learned something new, whether that's about Kaiser, about suicide, or just about Mental Health Research Network. And also kind of trying to start to plant some seeds for future partnerships. We currently don't have any projects that we're doing with the Colorado School of Public Health on the topic of suicide prevention, so it would be great to kind of think about that. Okay, what do we know about suicide? In 2015, the U.S. rate hit an all-time high, 30-year high of 13 people per 100,000. It's often cited as the 10th leading cause of death, although I find that to be kind of misleading, because people of younger ages, so from age 10 to age 35, it's the 2nd leading cause of death. And I think it's the 4th leading cause of death from age 35 to 55, and it's not until you get into the older ages where heart disease and cancer start to become more prevalent that it drops down to 10. Has a very high indirect cost because people die early in life. There's lost productivity costs associated with those deaths, so they say about $1 million in indirect costs per death. And for every suicide death, we see about 12 attempts that actually show up in the emergency department, and that number is sort of an underrepresentation of the total number of suicide attempts, the many of which do not go to the emergency department, and that's kind of roughly estimated at about 25 attempts per death. Colorado has one of the highest rates of suicide. We're about 7th in the nation. Some challenges with doing suicide prevention research. It's a relatively rare event, so you have to have very large sample sizes or you have issues with power. And so most of the information that you see out there for evidence of treatment interventions is looking at intermediate outcomes, suicide ideation, reductions in suicide ideation. The majority of evidence that we have in this area is from those. We have very little evidence looking at actual behavioral outcomes, meaning attempts and death. It's very difficult to obtain accurate estimates of suicide attempts. I'll talk about this a little bit when we get into the data part, but there's a lot of issues with coding for suicide attempts. There's a lot of stigma and sensitivity of patients not wanting to report when they have either suicide risk or where they've actually had an attempt. And we also see a lot of resistance among medical and even behavioral health providers to talk about the topic. And Marian Betts, if anyone knows her here, she does quite a bit of work in the emergency department on this issue. And finally, firearms account for about 50% of suicide deaths. And as you probably all know, there's a lot of political sensitivity around firearms. There are several policy studies that show that more expansive background checks and more restrictive firearm legislation leads to reductions in suicide. But obviously, trying to go the political route as a prevention technique, you're going to hit a lot of barriers. So we have to get a little more creative about thinking about firearms and suicide. And Carol does some work in this area, I know, speaking with local gun manufacturers. Okay, so just a little bit of background about Kaiser. We are a closed capitated system, which means we have both a health plan and a Colorado Permanente medical group that work together, but as separate companies. Nationwide, we have 10.2 million patients that are served by 7 independently operated regions, soon to be 8. Group Health in Seattle is soon to be our 8th region. So we have currently, this is like hot off the press as of this past month, we have 667,000 Colorado patients here, of which 75% are commercial or self-funded, 15.5% are Medicare, and about 9.5% are their Medicaid or charitable programs. 7,000 staff are physicians. We have 28 medical offices in this Denver area, of which 20 have primary care services, and we're currently expanding north-south and into the western regions. So our Kaiser's behavioral health care services, there are 3 large outpatient clinics kind of in different areas around the Denver metro area. We also have a crisis team that is available. They work out of the outpatient clinics, and they are available either in person or on the phone, which is really great for us in the research department as well as for all KP providers throughout the whole region. So if a primary care provider has someone who comes and shows up with suicide risk, they can engage the crisis team to help them manage that patient. And they will follow that patient all the way through to if they need to be hospitalized. We also have, as part of our integrated behavioral health care services, behavior medicine specialists, and those are primary care, clinic-based psychologists. So they work out of those 20 primary care clinics, and they are often the first line of defense again when primary care detects suicide risk. So they can seek patients the same day. They normally only provide short treatment, so about 4 to 6 sessions. And if a patient needs more than that, they would refer them to one of the outpatient facilities. Within primary care, sorry, I'm losing my voice a little. All right, so within primary care, we also have antidepressant management guidelines, and so primary care providers often treat depression in primary care using these guidelines, and those guidelines are based off the PHQ-9, which is a 9-item depression screener. So, for example, if a patient scores below 10, they should not be started on an antidepressant in primary care. If they score between 10 and 20, they should be, and if they're scoring over 20, they really need to go to behavioral health and probably be managed by a psychiatrist. And to support antidepressant management in primary care, we have a depression care management nursing team. So antidepressant adherence is notoriously poor, and so this nursing team is there to help support the primary care team to increase adherence. So they do calls with patients every 2 weeks to check in and see how they're doing with their new antidepressant. Check about side effects, which are common, and try to do some counseling with patients around side effects. And also they can change the medication if they need to using delegated protocols. And finally, we have an interdisciplinary group called the Depression Governance Council, and it is a group that has multiple departments that come together, including research, to try to inform depression care throughout the whole Kaiser region. And they often rely on us in the research department to kind of provide them with the evidence behind different treatment interventions. Okay, so the Mental Health Research Network, as you can see on the map there, it is expansive. We have 13 sites now throughout the nation, of which Kaiser is a member. So all of these sites are large healthcare systems with integrated medical and behavioral healthcare services. So other examples are Group Health, Harvard Pilgrim, all 5 Kaiser regions. Each of them has an embedded researcher or researchers with expertise in a variety of different areas. But when I say embedded, I mean they are embedded within their health system. That is their primary role. So the expertise in the network is expansive. We have psychologists and psychiatrists. We have epidemiologists. We have health services researchers, expertise in clinical trials, health disparities, qualitative research, and biostatistics. It's a highly collaborative network. We started in 2010. We have funding right now for the infrastructure portion through 2019. And when I say it's highly collaborative, I mean these relationships between the different systems are kind of ongoing, and so there's been a lot of trust that has been built up within this network. There's a very large sample size of patients, 12 million across all the different sites. We do a lot of observational studies and some clinical intervention research. And within this network, we have a variety of special interest groups. So there's a suicide special interest group, there's a comorbidity special interest group. And those are really great. They meet monthly, and they're a great opportunity for us to partner with a lot of outside academic collaborators who have content expertise in certain areas. So for example, here we have a very strong relationship with Sona Domingian at the University of Colorado Boulder, and we've done several studies with her looking at perinatal depression, which is her expertise. Okay, so I want to talk a little bit about, there's 3 different ways that we use our infrastructure funding. The first is to try to keep good relationships, strong stakeholder buy-in relationships with the delivery systems. And so this looks a little different at every site. So I'll talk about what it looks like for us. So at Kaiser, we have quarterly meetings with our behavioral health and other leaders to update them on what we're doing in research, and then also kind of hear from them what sorts of issues they're seeing and what maybe we could help them with. So we are both externally and internally funded, so we do a lot of quality improvement work in addition to larger outside trials. Okay, so a couple other ways we try to kind of stay connected with them is for the last couple of years, I've sent out a newsletter talking about what we're doing in research. And this past year, it's been a little easier for me to stay connected because one of our PI for the whole mental health research network, Greg Simon, has started writing this blog, which you guys can check out. He's a really funny writer. He writes the blog kind of for the behavioral health provider audience, and he writes it on sort of provocative, engaging areas. And so this last one was called Zero Suicide Aspirations and Accountability. It's about a pay-for-performance program that psychiatrists now have to participate in at group health. If they aren't doing suicide risk assessments when they should be, it affects their bonus pay. And so he posted his own results showing that he thought he would be awesome because he designed the program, and he actually would lose $300 of his bonus pay. Because of his results were not as great as he thought they would be. So his whole point is, aspirations are different than accountability. So obviously I sent this out to our whole behavioral health provider network, and it we had a lot of feedback on this. The idea of a pay for performance, people obviously kind of perk up when you talk about their pay. Okay, so switching gears, I'm going to talk about some of the patient data systems. So one of the other sources of our infrastructure money is to support data infrastructure. So we have a system called the ICOT, stands for Improved Care Outcomes Tool. And this is administered on an iPad at every single behavioral health care visit. It collects the PHQ-9, which is a depression screener, the GAD-7, or anxiety screener, and then the audit and the DASS for alcohol and drug use. It's used for two purposes. First, it's used by the treating provider to monitor symptoms, so they know, they have kind of a snapshot as soon as the patient arrives of what's going on with that patient. And they also can track changes over time. So I'll show you that here. This is what it looks like when the printout that the provider gets after the patient checks in. So you can see on there that, so the PHQ-9, this score is 15. It tells it that's kind of a moderately severe level. And then it also shows, you can see a little graph of what this patient has looked like over time. So it helps track treatment progress. The other use is for research, and we have several trials that heavily rely on this system right now. So it provides real-time data that's available for us that we can use for a couple of different purposes. We can use it for observational sort of outcome studies, but we can also use it for recruitment. So we can identify patients that have a certain level of depression or anxiety symptoms that may be appropriate for certain trials. This has really reduced our screen failure rate, and so it's better for patients because we're talking to patients that we know are probably going to be eligible and qualify for our trials. Okay. Virtual data warehouse. So the MHRN did not create the virtual data warehouse. It was around before the network formed. So the MHRN is actually part of a larger network called the Healthcare Systems Research Network. I won't get into all the details, but so I'll just say that the virtual data warehouse was there before we came along. And what we've done is used it and created what we call new content areas. So the virtual data warehouse it's not a centralized data repository. Each of the different sites has parallel standard data variables. So we have a set of variables at Kaiser, Colorado. They have a site in Kaiser, Northern California. They have a set at Harvard Pilgrim. They're all the same. And then at each site, we take our medical record data and we map it onto these standard variables. And this allows us to have very highly efficient collaborations with our other sites in an ongoing fashion. So we can write code at Kaiser. We can distribute it to 10 sites. They can pretty much just plug and play that code and run it up against their own data. And this also, so this is great for patient confidentiality because the PHI never leaves the institution. So if we send code out to 10 sites, they will send that code back. They'll send the results back to us in a de-identified manner. There's a lot of ongoing QA and development that is required to maintain the VDW. And so one of the first things we had to do starting in MHRN was data harmonization. So we had to validate the medical codes that we were seeing in the record against chart review to make sure these really were representing what we thought they were, that these depression diagnoses really were depression. So there's a lot of variables. I won't go through all of them on this slide, but so these are all the different kind of areas that we've looked at to validate codes. And I'll just speak briefly about, so the death data we have is pretty highly reliable. The suicide attempt data is probably one of our least reliable areas. There's a lot of between site variability in the coding. And so we have to always take kind of some extra steps with suicide attempts when we're doing studies. Okay, so when doing network science, it's really important that you do quality checks to determine if there's any between site differences. So if we get data back from 10 different sites and we see site A is quite different than site B, those variations could be due to data completeness. We could have issues with coding differences between sites or potentially missing data, or they could be due to differences in care delivery, which can be often interesting questions to look at. So unlike most of the studies in suicide, these are kind of my own observations, but I see that within the network, I think because we really tend to focus on suicide behavior outcomes, attempts, and deaths, our studies report absolute risk, so incidence rates. whereas most studies of suicide look at relative risk and attributable risk. We always try to put our results in terms of how they could be used by the medical providers or behavioral health providers, and trying to give a very kind of sort of unbiased assessment of how they should interpret them. Okay, so I'm going to try to kind of tell a little bit of a story about how we've tried to address this question of suicide screening in the general medical setting. So currently, suicide screening in the general medical setting is not recommended by the U.S. Preventative Services Task Force because we have insufficient evidence to either support or refute that practice. Basically, there's been no study that, because it would be a very, very large study, it would take a lot of power, there's no study that has been done that shows that if you screen this many patients and you will have this much reduction in suicide rates with these set of prevention interventions. Suicide, although we say it's a rare event, it is not that rare when you compare it to other things that are often screened for in primary care. So in the National Comorbidity Study, we see that about 13.5% of people report lifetime ideation and about 4.6% report an attempt. So if we compare that, for example, to cervical cancer, in women, the prevalence rate for that is 0.6%. But currently we have studies that show that if you screen for cervical cancer, you will have these, and then these interventions, you will have this reduction in bad outcomes. So the first step we took to try to address the screening question was, well, is the medical setting even the right place? Are there really even opportunities for suicide prevention during healthcare contexts? So we did this across, I think it was 10 sites. We had longitudinal data from year 2000 to 2010. I'm sorry, it was 8 MHRN sites. Just under 5,900 suicide deaths. And we collected information from the medical record, and then also within the virtual data warehouse, you have claims information and mortality records. And so some key results from this study, what we saw was nearly all individuals received some sort of health care in the year before their death. And one of the most interesting findings we saw was that 50% of people did not have a mental health diagnosis in the year prior to their suicide death. Now, this doesn't mean they didn't have a mental health diagnosis or they didn't have a mental health issue. It means it was not diagnosed in 50% of people. We also saw that in the 4 weeks prior to death, so pretty close, 50% of people had a visit, mostly with a primary care or medical specialty, and only 25% of them had a depression diagnosis or a mental health diagnosis. And so what we learned here was that, yes, there are opportunities in the medical setting because people are interacting with the system, and they're interacting with the system more than the general population prior to their suicide death. So in the first study, we weren't able to look at racial and ethnic differences, and we did that in a follow-up study. And in the follow-up study, I'll just kind of briefly talk about this one, but we saw kind of expected differences in that non-white people had lower rates of mental health diagnoses in their visits before suicide. And that sort of follows what you see in health disparities research. It wasn't really too unexpected. We saw some sort of interesting patterns for different visit types. So one of the most interesting ones that we saw, I think Kaiser Hawaii is looking into this, is we saw Hawaiian Pacific Islanders have far higher, like compared to all other racial and ethnic groups, far higher probability of having an inpatient or ED visit without a mental health diagnosis prior to their death, prior to their attempt. So the second study was looking at attempts. I'm not really sure what that effect is about, but it's kind of, with these sorts of descriptive studies, we're really just kind of looking at, we don't really answer a ton of questions, we sort of, it's a way to ask more questions. So I just wanted to show this. This is the demographics of suicide deaths for the MHRN patients from that healthcare context study. And the basic story here is that these look very similar to national rates. So some of the criticism the Mental Health Research Network receives is that our population is not representative, and And that may be true for some conditions, but for suicide, it appears to be pretty settled. Okay, so we now know that people are visiting with their healthcare providers before death. Now we want to ask, can we use a screening tool to actually detect people who are at high risk? So one of the things that all the investigators within the Mental Health Research Network have done since the beginning is really promote within their health systems the use of PHQ-9. And so because of that, we have a very, very large data set of PHQ-9s across all of these systems. And so we were able to look at whether SCORE on the PHQ-9 suicide question actually predicts, how people respond to that, actually predicts their risk of subsequent attempt or death. And so on the bottom here, these are the kind of where you see all the lines coming together, and the little dot by the 0 is day 0. So, and then going on the horizontal axis is the days since the PHQ-9 questionnaire was answered. And then it's the cumulative risk or cumulative incidence on the y-axis. And so you see the top line there, the dotted line, those are people that have reported that in the last 2 weeks they thought about thoughts of harm or thoughts of death nearly every day. And they have, over the year following that administration, up to a 4% chance of death, or a death or attempt. And then we see for the other levels, for the bottom level, they reported not at all, and then several days, and then more than half the days. So basically, as people report having more suicide risk, we see that this does actually predict suicide attempts and deaths. So we can identify a high-risk group. Oh, and sorry, there's one other point I want to make about this. One of the very important things came out of this was the immediate risk after that questionnaire is administered is fairly low. And that, as you can see in the graphic, the cumulative risk increases as you get up to about a year. And so the story we tell from this is that suicide is often detected as an acute problem, but it actually carries a chronic risk that goes, in this graph up to a year, but probably more than that. And so maybe we should be kind of rethinking about how we think about suicide and treating it more like a chronic problem versus just an acute problem. Okay, so kind of bringing this together, we wanted to do an intervention trial. So if you think about the screening question, we can now kind of do the first part of the equation. We can say we have a way to identify people that are at risk, but we don't really have a great place to put them because our behavioral health system is already overburdened. If we just started screening more people and sending them all to behavioral health, we just overburden the system even more. And so we got a year of funding to just prepare to do this trial. And during that time, at our site and at all the other sites, and this was led by Group Health, it's currently being led by Greg Simon at Group Health. So during that time, we had to first show that we had the data available for the outcomes, and that was fairly easy. The second part that was more challenging is we had to get a lot of buy-in from our behavioral health providers because we were going to be kind of interfering with care a little bit with this trial. So what came to be known as the Risk Assessment Care Management Intervention, as it would require a large amount of integration with the regular care delivery. And so we had to make sure that our healthcare system providers were really willing to adapt some aspects of that for the trial. We also, heard from them what is going to be sustainable, because we don't want to test something that we get to the end and we find out it's super costly and we can't sustain it. So we hear, okay, it has to be low cost, it has to be low intensity, and you have to only send us the people who are at the highest risk, because that's really all we can handle right now. For this trial, we are only looking at those folks that are in the top 2 lines here, so the ones that report nearly every day or more than half the days. And it's a 3-arm pragmatic randomized trial. We use a Zelen randomization. Have you guys heard of, anybody know what a Zelen randomization is? I didn't either. Okay. So a Zelen randomization means that patients are assigned to their group before they even know they've been in the trial. So we have a waiver of HIPAA, a waiver of signed informed consent. So if I'm a patient and I report that I have a high risk of suicide on my PHQ-9, I might get an email from Angela inviting me to do a skills training program. And I've at that point been randomized to the skills training program. So we have a skills training program in dialectical behavior therapy that uses an online program. That's one intervention. The other intervention is a care management intervention, and I'll talk a little bit more about that in a minute. And then the last one is usual care, and these folks we don't touch. They don't even know they're in the trial. Zell randomization, often there's concerns about, patient consent and confidentiality, and that is a risk, but it's sort of, when you think about the benefits versus the risk, the benefit of the trial is thought to, outweigh the risk in this situation. Our goal, we invite everybody in the whole health system who does a PHQ-9 and has a high score right now. So it's about 30 people a week that get invited to this trial. Our goal is to enroll 40% of the people we invite. And for the whole trial, our goal is to reduce suicide attempts and death by 20% in 18 months. I'll tell you a little bit more about the care management intervention. So we use evidence from a couple different places. First, healthcare context. We know that 50% of people at risk do show up for care in the, at least in even the month before they would potentially attempt their death. And hopefully we get a PHQ-9 from them. And then we also know that the PHQ-9 is predicting suicide attempts and death, so we can target that high-risk group. And then we also pulled from Henry Ford's Perfect Depression Care. And if you haven't heard of this program, I would very much encourage to go look it up after this. So Henry Ford did this kind of amazing suicide prevention program, and for 2 years they had 0 deaths per 100,000 in their health system. They went from 75 deaths, I think, to 0. And it was a huge system overhaul. They have a list of 10 different things that they did, and it's almost overwhelming to really think about doing that anywhere else, and it hasn't been done anywhere else yet. What they don't know about that program is which of those 10 things were the most important. And so this was one of them, that they treated suicide like a chronic condition, and they had people checking in with folks even after they said they were better. And so what we do for the care management intervention is we administer the Columbia Suicide Severity Risk Scale, and and then we have a risk stratification treatment protocol. So if you score a high score, you get checked in more frequently. You score a low score, you get checked in with at least every 6 to 8 weeks. And we have a licensed master's trained therapists that are our care managers for this program. And all of this is done using our patient portal. So patients receive this and they fill out the Columbia using an emailed secured link in our patient portal. And then the dialectical behavior therapy online program. It's called Now Matters Now. This is publicly available. You guys can go check it out. The version we use for research is a little bit different, but mostly the same content. It's created by Ursula Whiteside at the University of Washington. Marsha Linehan, who is the founder of Dialectical Behavior Therapy, which is a treatment that has been shown to have been shown to have a lot of clinical efficacy for suicide prevention, is prominently featured in many of these teaching videos. She's a very inspirational speaker. So we have Marsha's videos in this website, and then we also have lived experience. We have patients on there with lived experience that talk about learning these 4 skills of mindfulness of current emotion, opposite action, and pace breathing, and how it has helped them in their struggles. So to administer this program, we have 2, soon to be 3 skills coaches. One of them sitting right there. And they outreach and engage patients through the kp.org email. And they try to encourage patients to go onto the online program. One of the challenges with online interventions is attrition. And so if you don't have somebody that is kind of encouraging patients to use the program and keeping them engaged, they will kind of, tend to drop off. So that's their goal. And also to help them learn these skills, so they send them questions and start a dialogue with them to help them learn these skills and implement them in their life. This is what the Now Matters Now program looks like. You guys can visit it. They actually, I think fairly recently, added this lethal means section that I thought was really interesting, because that's an area I'm very interested in. Okay, so next steps. We think about suicide in 3 groups of patients from the work that we've done. First group is that 50% of people who die without a mental health diagnosis. Guys, I didn't tell you this earlier, I kind of forgot, but I can ask. Who do you think they are? Yep, none. What else?
Very low insurance.
So everyone in this study would have insurance. What about income, education? What do you guys think? Low income, yeah, low income, low education. So we know that. We don't really know a lot more about them, though, at this point. And so one of the studies we're currently doing is called treatment utilization before suicide, and we're looking at all people who die by suicide. But we're really trying to see in this group, are they more likely to have chronic health conditions? What sort of physical health conditions do they have? We're looking at all the other stuff in the medical record besides the mental health stuff to see if those are potentially predictors for suicide risk. So the second group we think about is 25% of patients who die by suicide, and they are known to the mental health system, but they have not been in care directly before their death. And then the last group is the 25% of people who die who are currently engaged in care. So our SPOT trial is really looking at groups 2 and 3. We don't have any current work that really looks at group 1. And I sort of wonder, I don't even know, and I don't know if anybody knows, if the medical setting is even the place to look at these folks, because we don't know who they are. We can't go to our primary care providers and say, can you just screen all men? They don't have time for that, and we don't have the evidence to say they should do that yet. Okay, so some concluding thoughts. We are, building research networks provides opportunity to pool data to increase sample size and power for detecting suicide, which is a fairly rare event. So, prior to the Mental Health Research Network coming along, I think the only studies in the U.S. at that time were the Veterans Administration that could really look at outcomes, behavioral outcomes. Since then, there have been a couple large networks on the East Coast that have done this, but they haven't been closed systems. And so the issue when you don't have a closed system is that you don't have complete data. So, and big data has really changed the way we think about suicide prevention and has identified these gaps, like that 50% of folks that aren't seeking mental health care services. We have a lot of hope for web-based mindfulness interventions. There's the Now Matters Now program that I told you about. We're also doing another study called Strategies for Overcoming Residual Depressive Symptoms. It's a prevention study. We're using a web-based, mindfulness-based cognitive therapy program. And in that program isn't specifically for suicide. It's for a depression, but suicide could potentially be a secondary outcome. And then we're getting closer to building this evidence support for primary care-based screening for suicide risk. So very interestingly, in February of this year, there was a Sentinel event alert that came out from the Joint Commission, JCO, and it was on detecting and treating suicide in multiple settings, in healthcare settings. And they cite 3 of our studies that I talked about here in this report, and they kind of make a soft recommendation for screening of all patients for suicide, and then they also identify a list of risk factors that primary care and general medical providers should be asking more about to determine whether there is suicide risk. So we have that, as I said, we have that sort of first part of the equation for screening. We have to figure out, will a program like SPOT be a prevention approach that you could use to reach a large number of people. And then if you're interested more in what we call our learning healthcare systems, we consider ourselves a learning healthcare system, as do most of the Mental Health Research Network sites. There was an article written by Rebecca Rossum at Health Partners called Facilitating Action for Suicide Prevention, and it talks a lot about what we've done throughout the network, how we've worked with our health system partners, and some of the impacts that we've realized within our systems. Okay, questions? Hey, Rich.
Great job.
Thanks.
Really good. Yeah, I have a question about the So you had the chart with the cumulative probability.
You would ask me about the data. Go ahead. Yeah, I'll go back to that.
Yeah, I thought it was interesting. And,
Okay.
especially the slopes
Mm-hmm.
indicating that it's really important. Account for that in the randomization, or is that?
So this is observational. It's not randomized in this study.
Or I mean, for the trial. So I would guess kind of usual source of care.
Yeah.
Then in the trial, it would seem like if you intervene.
So we intervene at point 0.
Oh, 0.0.
Yeah, so we intervene within a week of them scoring a 2 or 3. Yeah. This is, I find this super interesting because at the point 0, you would assume that the healthcare system does something when they detect risk, so that may be why you're not seeing a lot of risk right away, but then people sort of can fall off of care. And that's what we think for the care management intervention is we are able to kind of continually be keeping people engaged with their care that way. And so we're evaluating 18 outcomes at 18 months. Yeah.
Yeah, just to add to that, where that connects with the care that involves ongoing risk assessment. Trying to kind of address this ongoing assessments at various intervals allow the provider, the care manager, to determine if higher acuity setting or
Great presentation. Thank
Thanks.
you. I have 2 questions. My first one is, what age group is in part of the trial for the Now Matters Now program? And then my second question is, do you guys have a way to contact people that's not via email or that's part of the trial?
Great questions. So you're asking about the age group of the people on the website or of the trial?
That were randomized.
They're adults, so we don't do any kids, but anyone over age of 18 is randomized. And sorry, what was your second question?
Is there another way to contact them? That's
Yes, another way to contact them for the trial. So we mostly do this via email. Email, I mean through the patient portal. We do also, if they don't respond to the patient portal, then we call them. Yeah.
How do you assess? You said that you only take people who use the patient portal like pretty frequently. How do you assess that, and what's kind of your?
Yeah, great question. So it's a limitation of the trial is we only are including people that use the patient portal, so they have to have received or sent an email in the last year to be randomized, and we lose about 20% of our people because of that. So we have a very high level of folks. 80% are using the patient portal, but we do lose some because of that. Yeah, sure. That's a great question. I was reviewing this article recently again, and that not at all group, a fifth of them have risk, and it could be 2 things. It could be, suicide risk is transient, so it could be when they were evaluated they didn't have any risk, and they were honestly reporting, and then they had some risk later. So the group that is screened, there's going to be a reason they were screened, right? They probably have depression. The other is they're not reporting honestly. They don't want to report suicide risk for a variety of reasons having to do with stigma and sensitivity around that. So there is some risk in that not at all group. Yeah, no, there is. They have some risk. Yeah. Yeah.
Is Boggs something that is publicly?
It is. Yeah, you can check it out. There's a couple other articles on there that are, pretty engaging. So, let me just go back to it. I think I put the website on here. If you just Google Mental Health Research Network, it's on our website. There's a link to the blog on there. Yeah.
I'd love to hear a little bit more about some of the other work you're doing.
I knew you were going to ask me that.
You've got a lot of stuff going on.
Yeah. So I was telling Carol when I first put this talk together, it went an hour and a half, and I had to cut a lot of things out. So there's a lot of, I told her the main plot, but there's a lot of subplots. So let me just go down here. I'm going to talk to you a little bit about one other project that we're doing you guys might find interesting. So I told you a little bit about SOAR. talk about this one. So this is one I'm actually leading. It's STAR stands for Strategic Target Allocation of Resources. It's an internal funding from Kaiser that I got, about $40,000 to look at building a algorithm using natural language processing. You guys know what natural language processing is? Okay, so it's a way of using like machine learning to read text notes. And so I wanted to try to see, could we accurately identify when conversations about means restriction or just means at all, assessments for means, meaning firearms and other means that may be used for suicide, if we can detect when that's happening in the chart. And so we know that means restriction is one of the 3 most effective interventions for preventing suicide outcomes, and when it's evaluated in a policy context. We don't really know if means restriction counseling is effective. And so that is kind of the direction we're going with this, is if we can accurately look at, accurately identify when these means restriction and means restriction conversations are happening, and when they're not happening, because they're not happening all the time when they should be, we may be able to kind of evaluate whether means restriction counseling is leading to reductions in suicide outcomes. That's one other project we're in the middle of. It's going quite well right now. We're kind of we're using SAS text miner and then a program called Lingomatics for the natural language processing.
The entire patient record.
Yes. Well, we narrowed it down. So for this study, we narrowed it down to, I thought, okay, so talking to our behavioral health folks, the most likely time when you're going to see a means restriction conversation happening is after someone has an attempt or after they score 2 or 3 on the PHQ-9. And so we looked at that month after they have an attempt or the month after they score 2 or 3 on the PHQ-9 to see how this is being documented in that kind of high-risk time frame. And so right now we have identified all sort of the words that are used for this through chart review, and we're currently in the process of building the query and testing the query.
Did that pick up one of your patients in the emergency department, or did that get back into the record that you can query?
Yeah, actually, and so another slide I had to cut out. I have it down here somewhere at the end. Okay. So the data systems within Kaiser, you can't see the blue dots, but all the blue dots are Kaiser-owned facilities, and from those facilities we get all the medical, outpatient, health record information, and then from all those orange facilities, and those examples are like Denver Hospice, Sobriety House, an autism center. They are a wide variety of places where Kaiser patients can visit that we are not Kaiser-owned. We get claims information, and then from EDs and inpatients, we get full medical records now through the Care Everywhere EPIC program. So we can actually, I was really surprised. I didn't think we'd be able to read ED and emergency and inpatient notes, but we can. For not every hospital, we can only do it with the Denver hospitals. Like if somebody goes to a hospital in Nebraska, we can't do it. But yeah, we can read a lot of those notes with the natural language processing. Yeah, got that one too. So I'm currently working with this group and leading a paper looking at, before I get there, I'll tell you a little about treatment utilization before suicide. So this is sort of this next phase of observational studies after healthcare contexts. It's a match case control study. We're matching people who have suicide deaths 100 to 1. And the reason for that is so we can do more matching later if we want to. But we start 100 to 1. They're just matched by site and year of death. So we want to develop a predictive model for suicide risk and looking at a wide variety of factors in the medical record. But really the trial was written more for the non-mental health factors, the physical health issues people could be having, and how those may cross with some of the mental health factors. So our findings to date show that the highest risk condition for physical health condition is traumatic brain injuries. So the odds ratio on that, even after adjusting for mental health and other risk factors, is 9. And the other story about this is that even though TBIs have this very high odds ratio, almost all chronic conditions are like above 2. So there's risk convened by a lot of chronic conditions. So right now, the paper that I'm working on with Brian Amadani, who's the lead PI on this at Henry Ford Health System, we're looking at differences in people who die by firearm suicide versus people who die by other means of suicide, and seeing if my hypothesis is the folks that die by firearm suicide are going to be more likely, and this seems to be looking like it's going to happen, are more likely to have physical health conditions. And the folks that are dying by other means are going to be more likely to have mental health conditions. Yeah. No, we don't have occupation. We have education and neighborhood income.
What veteran patients?
Yeah, we have veteran status in there, but not their actual occupation. And one of the things Arnie and I talk about is financial stressors. Which is not something we always have, but we kind of feel like they should be asking more about financial stressors as a predictor.
Highlights, where there are gaps in asking for patient-reported. Capturing some of that information in the electronic. Social measures, codified in the
Yeah.
hypothesis behind taking.
Yeah, so my hypothesis was they wouldn't be in the mental health group because the folks that are dying by firearm suicide are more likely to be men who don't seek those services. And so what we're seeing is if you have a chronic condition, you may be at higher risk. And so for example, if you have ALS, it looks like data hot off the press I got like yesterday. It looks like if you have, so don't hold me to this, but it looks like if you have something like ALS, your risk of dying by firearm suicide is far higher and significantly higher than your risk of dying by another mean.
Challenge in gathering data on children?
Yes, yeah. I mean, I think that would be a challenge with any research on children. There's a lot of confidentiality issues, especially with teens, around sensitive topics like this. So I haven't done a ton of work with kids, and we haven't done a ton of work with kids, but I know that there are some others in the network that are doing that work, and I know that can definitely be a challenge. Like if you wanted to, as a researcher, interact with a teenager directly, at what point do you have to sort of bring their parents in, but you still want to maintain that trust with them, right? Yeah.
Providers use telehealth.
Yes.
At comparing telehealth interventions.
We haven't looked at that yet. Telehealth is very new. Started, maybe a year ago? Something like that. So they started being able to do video visits with only certain types of visit types, mostly follow-up check-ins type visits. The psychiatrists use it, I've heard, quite a bit, use the telehealth video visits. But no, we haven't. It's a good question. We haven't looked at that yet.
Talk about telehealth, they often think about sort of more the fancy video link. Actually do a fair amount of care management.
Yeah. Kaiser does a lot of telephone-based work.
I'm asking that because the study that we're putting together right now, we're finding that a lot of providers tell us they're using telehealth. Not sure
what that means.
The extent to which that should be considered equivalent.
So there's some pretty good research by effective in managing. evidence out there that
Studies going on with nurses, with the nurses.
You asked the question is, are there any studies that are currently going on with the local schools? We don't do that on our team, but our community benefit department does work with schools quite a bit, and they are doing, Sam Hubley would be a great person to talk to about this. He is working with a group in community benefit, and they're looking at doing this, what's it called, Arnie, like the mental health sort of like training, the movie minute, yeah, with students, so to kind of build up mental health resilience among young kids. So, but no, our group, we aren't currently working with the schools.
Thank you so much for your presentation.
Thanks.